Okay, now I would like to invite the next moderator, Dr. Fiona Olvita D'Souza. She is currently working as Head of Scientific Operations in clinical genetics at Anderson Diagnostics, and she has obtained her PhD degree in clinical embryology from Manipal University. And her present role is heading product division and genetic counselors team. And her area of specialization remains both invasive and non-invasive PGT and embryo metabolomics. To her credits, she also has published multiple papers in peer-reviewed and highly indexed journals. Welcome, Dr. Fiona. Over to you.
Thank you, Tejaswini. So I'm here to introduce our next speaker, who does not need much of an introduction. So we have with us today Dr. Alpesh Doshi. He is well known in the field of pre-implantation genetic testing and embryo biopsy. He is a consultant clinical embryologist and co-founder at IVF London. He's also the co-founder and director of embryology at the Institute can I have the CV, please? At the PGT Academy, sorry. He's previously worked at the Center for Reproductive and Genetic Health as the director of embryology for almost 19 years now. And he has graduated in human reproductive medicine from the very prestigious Imperial College and School of Medicine, London. So Dr. Alpesh Doshi is here to talk to us on quality control standards in PGT. Over to you, sir. So you're on mute.
Hi, can everyone hear me?
Yes.
Brilliant. Thank you so much, Fiona, for that kind introduction. Absolutely a pleasure to participate on a webinar and obviously impart the little knowledge that I have around the whole PGT area. So with time ticking along, there's a lot to go through, and I'm going to be whizzing through a lot of the slides. But if there's any questions at all, please do feel free to ask me at the end. I'd be more than happy to answer them. So the talk today is really revolving around biopsy, PGT, and from an embryologist perspective, what are the key performance indicators from a quality control perspective that really we should be monitoring? Now, of course, the whole area of PGT has been around for many, many years. Like anything, there has to be a curve of proficiency when it comes to your embryologist learning the procedure for biopsy, and this is an area of special interest for me. So I sit on many kind of bodies kind of advising on what the KPI should be when it comes to PGT and embryo biopsy. So just to recap, we all know that blastocyst biopsy has almost become a gold standard now, and we should be aiming for at least 50% of our fertilized eggs to reach blastocyst. And of course, this is very age dependent, patient dependent, cycle specific, so there can be so many variables in this. But I would always recommend that look at your egg donation cohort. That is your gold standard patient, and you should be getting at least 50% blastocysts of fertilized eggs. So once you get that, you know that your lab and culture conditions are pretty decent. Blastocyst biopsy rate. Now, all the embryos that are at the blastocyst typically should have around a 99% biopsy rate. Blastocyst-free survival rate, we all know that with the advent of vitrification, we should be getting over 95% survival of our blastocyst post-thaw. Number of cells biopsy from embryos, typically 5 to 10. Number of embryos that you get results from, you should get results from about 95% of your embryos. Contamination, again, should be very minimal. There should be less than 1% contamination in any cells that are tubed. What is the rate of not obtaining results from PGT samples? Less than 5%. And of course, the gold standard KPIs are always pregnancy rate and miscarriage rate. So I took the opportunity to kind of tell you a bit about the PGTA success rates, because this is typically what we do day in, day out in terms of the volume and with any kind of PGT. So typically we would kind of raise an alert if our PGTA pregnancy rate dropped less than 60%. And of course, the miscarriage rate should be less than 5%, especially for PGTA cycles. So I just want to take you through a bit of a memory lane of different types of biopsy techniques that are used, and I'm not going to spend too much time on what we call the antiquated techniques. And we all know that polar body biopsy is one such procedure that started in the 90s, but nowadays has totally phased off, and we're no longer carrying out any polar body biopsy due to its own limitations of not being able to analyze the embryonic genome, and you can only analyze the maternal genome and not the paternal or post-zygotic events. So those of you who are just interested in seeing what a polar body biopsy looks like, so it's make an opening at the zona pellucida at around 1 o'clock, and then using that pipette, which is about 10 to 15 microns in internal diameter, to aspirate the polar body out of the zona pellucida. So we'll move on, and this is another video which is showing taking the first and second polar body out both at the same time. So an opening is going to be made at around 1 o'clock again there, and the pipette is going to be inserted through that opening, and the first and second polar body are both going to be taken out at the same time through that.
Dr. Alpesh, sorry to interrupt. Could you please go on a full screen mode? We're still on a...
Oh, really? Oh, sorry. I don't know what's happening there. Display settings. Oh, you can't see?
We can see, but the screen is smaller.
I'm trying to see what I can do here. It paused. Oh, I don't know what's happened. Okay, sorry. Okay, but my slide is not moving now. Okay, don't worry. I got it. So we're not going to go into the pros and cons of polar body biopsy. Again, as I said, this is a method of the past, and so is cleavage stage biopsy as well. And I know that some of the labs still around the world do a lot of cleavage stage biopsy, more in the Middle East, because gender selection is still allowed in that part of the world. They're not really interested in, you know, getting a comprehensive idea of the aneuploidies. They're more interested in just looking at the XY18 chromosomes. So they still perform a day 3 biopsy with a view to putting that embryo back in a fresh cycle. Because again, with blastocyst biopsy, we know that one of the limitations is that we have to freeze the embryos and then perform an FET cycle in order to put the embryo back. So in many countries where cost is an issue, when you can't, you know, when you don't want to lose that patient by asking them to come back for another cycle, or they're traveling from abroad, some of the clinics prefer to do a day 3 biopsy. Although I must say that I don't validate this technology anymore, simply because there is more hassle than worth. The accuracy of the test can anyway be questioned. And secondly, there is evidence to suggest that day 3 biopsy results in a lower implantation rate compared to blastocysts. But just to show you the videos, this is how we do a day 3 biopsy. We make an opening in the zona pellucida with a very, very precise laser beam, and making an opening of around 20 microns internal diameter. We then use a pipette, a polished pipette of around 30 microns internal diameter. And through that opening that we have made, we would just aspirate a couple of cells. Now, this technique is called aspiration. And we just take that one cell out, and we will now try and take a second cell out. And of course, I know that in many labs, the policy may only be to take one cell, but going back in the 90s, when we were performing cleavage stage biopsies, our genetics lab always preferred us to take 2 cells out of the embryo, especially for any kind of PGD or PGTM or PGTSR. simply because they wanted to have the surety of the diagnosis and, of course, look at the mosaicism elements as well. So moving forward, this is another technique whereby, we would apply the laser beam, but the thing with this technique is that I'm using what we call a displacement technique rather than the aspiration technique. So you can see that I'm just making an opening with a laser beam first, and then what I'm going to be doing is I'm going to be blowing some culture media into the embryo in order to displace the two cells. So this is a slightly different technique. Again, I don't endorse this technique at all because we've stopped doing cleavage stage biopsies since the 2016, 2017, we completely stopped doing cleavage stage embryo biopsy, and we fully migrated onto blastocyst biopsy now. So what you'll see in this biopsy is we're going to be blowing some. Hello? Yeah. So there we are. We're going to be just blowing some culture media soon. And Fiona, I don't have the timer in front of me, but do please prompt me when I'm literally just 3-4 minutes away. Yeah.
Yeah, sure.
Thank you so much. So there we go. We just blew some media into the embryo, and we got 2 cells out. Again, we're not going to go into the pros and cons of this. The talk can be very long. I'm conscious that I have only 20 minutes. So again, this is a technique of the past. So let's move forward onto blastocyst biopsy, which is more something we do nowadays and has almost become the gold standard of PGT in terms of sampling of cells. So the zona drilling has to be done. Of course, you need to access the trophectoderm layer of the embryo. We make the opening on day 3, 4, or day 5, depending on the preference of the lab, the embryologist. At this stage, we all know that the embryo has differentiated between the trophectoderm and the inner cell mass. So the idea being that we want to take 5 to 7 cells out of the trophectoderm layer. Of course, the excision can either be done via a manual method, which we call the flick technique, or you can use the laser in order to isolate the cells. Now, what are the pros and cons of blastocyst biopsy? The benefits are that you're taking a larger number of cells compared to cleavage stage biopsy. It is still a smaller proportion of cells that you are taking compared to a cleavage stage biopsy. So also, although you're taking 5 to 7 cells, you have over 150 cells in a blastocyst. So you're taking a smaller proportion of cells. The drawbacks being, which I said at the beginning of my talk, you have to ensure that you have a good culture system. You have good culture conditions. You've got good air quality. You've got good embryology. You need to have a good blastocyst formation rate before you start tampering into these tertiary techniques like blastocyst biopsy. So it's very important that you have your basics correct. Your basic KPIs have to be in line before you embark onto any kind of PGT work. Of course, mosaicism is still there. We're not saying it's not there, but we want to make sure that we try and minimize incidence of mosaicism as well. So just a cartoon to show when the opening can be made. I prefer making my openings on day 3. And of course, there's a risk that by day 5, the inner cell mass may be hatching out. But we have biopsy techniques now that circumvent that problem, and I'll show you that in a minute. So this is typically how we do the biopsy. So there's a nice balloon hatching out of the embryo on day 5, just holding on to some trophectoderm cells with my biopsy pipette, and then applying the laser to dissociate the cells. Now, of course, from a technique perspective, it is very important that you stretch the cells as much as you can so that the laser can have an effect on pulling the cells apart. So there we go. I've taken a small biopsy. The embryo hasn't even felt it. The embryo cavity is still intact, and I've managed to take around 5 to 7 cells. So I'm just going to decrease the magnification on that in a while. And you'll see that the embryo is still very much intact. And the cavity may collapse sometimes, and that's normal. Don't worry about that. But in this case, the cavity is still alive and it's still fully expanded. And you can see the small biopsy there at the bottom, and this is what is going to be tubed for genetic analysis. So what happens when the ICM hatches out? And in this case, you can see that the inner cell mass is hatching out from the opening that we have made on day 3. Now, again, you know, it is possible. What I tend to do in clinical practice nowadays is to make a second opening in the, you know, in the zona pellucida, and through that second opening, go into the embryo. Of course, we try and make that second opening a bit smaller so that there is not, the embryo doesn't try and herniate from 2 different sites. So you can see that that second opening is much smaller, and we go in with the pipette, aspirate some cells through that second opening, and then use the laser to excise some of those cells. So there we are. I'm just going to fast forward a bit, just so we are making a move. There we are, just applying the laser again, very gently at a much lower intensity. And once the laser is applied there, the laser has started now to act. And we just keep on pulling on the cells very gently. And through that opening, we just pull the cells and exit the embryo. There we are. You'll see in a minute that the cells are just going to shear off quite nicely from the remaining embryo. There we are. So that's how we would tackle a case whereby the inner cell mass is hatching out. So again, without wasting too much time, there have been studies that have compared blastocyst biopsy with cleavage stage biopsy, and it has been seen that cleavage stage biopsy of even one cell does reduce the implantation rate by 20%, whereas blastocyst biopsy, there is no difference between the biopsied and control group. So again, indicating that any kind of cell sampling at the embryonic level should be restricted to the blastocyst stage. We all know that mosaicism is one of the very common problems nowadays. Of course, not nowadays, it always was, but less so in blastocysts. But mosaicism does exist in embryos. We know that the results that we get sometimes do show low mosaicism, high mosaicism. So it's very important to really have the know-how on how to counsel your patients about mosaicism, because when you get those embryos, or if you only have a mosaic embryo, how are you going to relay this result to your patient? How are you going to explain it? Of course, it may be important to give them an opportunity for genetic counseling as well. So we also know that mosaic embryos have led to pregnancies and live birth. So you can't take that away from the patient if at all that's the only embryo they have. We all know that the universal results that we would see is either a euploid embryo or a universally aneuploid embryo, universally euploid embryo, a mosaic embryo whereby there are a mixture of cells, aneuploid and euploid embryos, aneuploid and euploid cells, both in the trophectoderm and inner cell mass, of course. But in cases whereby the mosaic cells are limited to the trophectoderm, we all know that confined placental mosaicism does exist. So maybe the embryo has a mechanism of throwing out abnormal cells towards the trophectoderm, which is where we're picking these mosaic cells up, and yet the inner cell mass is totally clear. And it could be these embryos that result in a pregnancy and a live birth, of course. Some words of precaution in the laboratory. We still tend to use ICSI for any kind of PGT-M. We tend to use IVF for PGT-A and PGT-SR. But I know that the genetics lab have now told us that, look, because so for karyotype mapping, we tend to certainly still use ICSI as the technique to inseminate the eggs. Witnessing is paramount, of course. It goes without saying that you need to witness embryo number 1 going into embryo number 1 dish, embryo number 1 being biopsied, put back into embryo number 1 dish, and embryo number 1 being then be frozen, and the labeling of the straw and everything being checked, the labeling of the Eppendorf tube, everything being checked. Here we are not witnessing the patient details, we're witnessing the embryo number details, because any kind of mistake here can result in a misdiagnosis, which can...
You have 2.5 minutes left.
2.5 minutes. I will shoot through these few slides. So I always feel that the role of an embryologist is very diverse in an IVF laboratory nowadays. So apart from just doing these procedures, we need to have the interpretational ability of how to translate these embryos. So of course, we know that for PGTA, you can have all these different nomenclature of results, euploid, aneuploid, low mosaic, high mosaic, and I'm not going to go into all the details because we're short of time. But for this is typically a PGTA result. You can see that this patient had quite a lot of embryos, one euploid embryo, and so many other different categorizations. She had a low mosaic embryo as well. Now, of course, the priority model of transferring an embryo, always try and go for the euploid embryo first, the best quality embryo first. But again, if there is nothing else remaining, then you may want to move towards the low mosaic, then potentially the high mosaic, and totally avoid transferring embryos with any viable trisomy. Even for mosaics, if the mosaicism is to do with a chromosome 13, 14, 16, 18, 21, these are best avoided because you do not know what degree of effect it may predominate with. PGT-SR, again, same thing, different nomenclature. It's important to understand that with any kind of structural rearrangement where you're looking for a balanced translocation, you must counsel your patient that you will not know whether the embryo is normal or has a balanced translocation. If it's an unbalanced translocation, of course you're going to know, but if it's balanced, i.e. the same type as the parent, you are not going to know. So you've got to counsel your patients that transferring an embryo doesn't mean it's free from the balanced translocation. It may simply phenotypically be like the parent. This is typically a result that we got from a patient with a balanced translocation, 3 embryos there, some of them didn't have any DNA detected. Going to PGTM, as you know, you could have dominant conditions or recessive conditions. And of course, in this case, we did it for multiple hereditary exotosis, and we saw that there was one embryo that we could transfer because there were at-risk haplotypes in 2 of the embryos, and then one embryo number 3 had nothing there. We transferred it, we got a pregnancy. PGTM, again, could be for a recessive case, both parents carrying obviously a recessive condition, and both of these genes have to then predominate in the embryo for it to be affected. Again, in this case,
sir.
Yeah.
Time is up.
Time's up. Okay, so that's my last slide. And yeah, so all I'm saying, the future is very bright. Look out for non-invasive PGTA. I'm sure we will be able to take just culture media from the fluid, and we're going to be able to get cell-free DNA from it. And I think the biopsy is going to be something of the past anyway. Thank you so much. I'll stop screen sharing.
Thank you, Dr. Alpesh, for that wonderful talk. We can take questions now. Okay, I have one question until then. Dr. Alpesh, could you tell us what would be the technical ways we can limit mosaicism in day 5 embryo biopsy?
There isn't much you can do because, as embryologists, we don't know where these mosaic cells are sitting. There is no clear patch it can be in. An embryo is 3-dimensional. We don't know if these mosaic cells are just are spanning the whole embryo or are sitting on one side of the embryo. There is absolutely no way to know it, Fiona.
Okay. Would you say that a biopsy of 4 cells would have a higher incidence of mosaicism as opposed to a biopsy of 6 to 8 cells?
That's a very good question. I generally don't like taking too few cells purely for that reason, because the whole ratio of the cells can take. But one can argue that if you have universal mosaicism, then the ratio of cells that are abnormal to normal would be quite consistent. So whether you take 7 or whether you take 4, if you take 7, you will potentially have higher abnormal cells, or the ratio would not be changing per se.
Right. Thank you so much. Pleasure to have you with us, and thank you, Team Hera, for having us here. Over to you, Tejaswini.
Yes. Thank you, Dr. Alpesh Doshi, sir, for the insightful lecture on quality control standards in PGT. Thank you, Dr. Fiona.